All right, it's 8:01, and I'm going to go ahead and get started, and the lights in the back just got turned on, so that's fantastic. So thank you, everyone, for spending an hour with us again on a Friday morning for what's going to be a fantastic Grand Rounds. My little shout-out to nature today is that it is a harvest moon tonight, and so what a harvest moon is a full moon in September, and the little fact about this harvest moon is it's the only harvest moon that will occur for 30 years on Friday the 13th, a day I actually happen to love. So, with that, we have another one of our incredibly talented professors, Dr. Christie Bartels, presenting today, and she's going to be talking on lupus disease, disparities, and new directions, strategies from HIV and beyond. Christie is here in our department, and Dr. Bartels is in the Division of Rheumatology. I'm going to talk a little bit about her so you can get a flavor of how incredibly much of a triple threat she is, just as Dr. Burkhart was last week. She did her medical degree at Creighton University School of Medicine. She was a medical scholar there, and we were lucky enough that Dr. Bartels decided to then make us her forever home after that. So she has done her internship and her residency here, followed by chief resident. She did her fellowship in rheumatology here at the UW-Madison School of Medicine and Public Health, and she also has completed a master's in population health here as well. I do want to give actually a little bit of applause right now. Last year in 2018, she was promoted to associate professor tenure track, which is absolutely fantastic. She has over 55 peer-reviewed articles. She has 5 current grants with many more pending. She's done over 18 national and regional talks. And I thought what was most impressive on her CV when I went through that last night was she has mentored over 30 faculty, fellows, residents, and medical students, me being one of them. My first article ever published was with Dr. Bartels' mentorship in Journal of General Internal Medicine, so that was really incredible for me. And when I looked at the production of the people she has mentored, they have more than 85 papers, grants, posters, and presentations. And interestingly, when I always ask someone what they're most happy and fulfilled about their career, it was her mentorship, and that clearly shows. The other thing about Dr. Bartels that she told me today is that one of the things that she's known for academically is really being able to define for all of us that cardiovascular disease happens 2 years even before the diagnosis of lupus in people. Just a couple shout-outs for awards and honors for her. She has had 3 years of UW Health Patient and Family Experience Provider Champion Award. That is to the top 5 clinicians across UW Health. She has received the UW Department of Medicine Prusto Research Award, and she has received the Arthritis Foundation Community Impact Leadership Award. And I want to say that she and I have really grown up here together at University of Wisconsin, and she is a shining star at our institution and will be going forward. And so I'm very honored to have asked Dr. Bartels to come up and present Grand Rounds.
Thank you. Thank you. Thank you. So thanks for that great introduction here this morning. And I'm excited to talk with you all about a topic that is really interesting to me, and I'm hopeful that you'll all glean some pearls along the way here today, too. One kind of funny, timely factor here is that yesterday I actually got a request for a media consultation because apparently pop culture star Khloe Kardashian thinks she might have lupus, which made me laugh. So this is also something that may help your pop trivia knowledge. So we'll just put that out there today, too. But the real reason I care a lot about lupus is one of the things that is sort of interesting about this is did you know that lupus is actually a leading chronic disease cause of death for young women in the U.S.? It turns out that actually among black women and Hispanic women, it actually ranks 5th as causes of death for women under the age of 25. And it's, again, a top cause for all women in the U.S. And I think that actually can be kind of humbling because we think of lupus often as a relatively rare disease, and so that actually tells us that it has a huge impact. It impacts about 1.5 million adults in the U.S. It's about 90% women, 2 to 3 times more common in women of color. And one of the things that we mentioned before is that some of my research is really focused on this idea of cardiovascular disease, which happens in women in the 45 to 50-year-old age group, 50 times more likely than peers. But one of the other things that's grabbed my attention in recent years is facts like in some cohorts they're showing that there's 7-fold higher rates of end-stage renal disease and 2 to 3 times higher early mortality in people of color. And just wondering on some of those questions, how much of that's physiologic and how much of that might be mediated by care delivery. And those are some of the questions we've asked. So as I talk through today, I'm going to go through 3 sections. And the first section actually will be just telling you some epidemiologic stories and maybe unraveling a bit of the mystery. And I'm hopeful by the end of that portion, you'll be able to have at least 3 new facts on lupus. And some of you may have learned a fact or 2 already in that introduction, so keep listening, all right? This is great. The second section actually will talk about some of our own research, and we'll be talking about things like the new diagnostic classification criteria and some of our research, including where we've used an HIV model to think more fully about HIV or about lupus care delivery, things that could help promote health equity. And by the end of the talk today, I'm hopeful that we'll have also provided some practical strategies and that you'll have some ideas of some team-based concepts or interprofessional kind of chronic disease management type steps that you might actually be able to apply in your own practice by the end of the talk today. My quick financial disclosure is that among other funders, we do have one grant that is from the Independent Grants for Learning and Change from Pfizer Corporation to promote non-pharma smoking cessation intervention. And just to get us started, I'm actually just going to start with a really basic epidemiology slide. So this is a study that actually was performed in 2 counties in Atlanta where they captured all of the cases of lupus. And they did this by getting a public health authorization to get all of the people who had ever had a positive ANA or who had ever had kidney pathology or who had ever had a visit to a nephrology or a rheumatology clinic with anything remotely looking like lupus. And they were able to then capture the population level prevalence and incidence of disease. And what they were able to demonstrate, actually, again, some of these things are things that you all know and learned in medical school, is that the disease obviously was more prevalent among patients who were black, in the black triangle, or the black diamonds versus the white circles. But they were able to show again that prevalence peaks at age 30. But if you take a look down here at the white patients, this is something we've demonstrated also in our own data at the Marshfield cohort, is that actually there's a late onset peak after age 50 that's more common in white women. So this is actually useful to kind of think about, that second prevalence peak is at late onset. And interestingly, in that late onset group as well, the gender ratio flips from 9-to-1 to actually 5-to-1. So there you might actually see some men in this late onset group too. So just when you're thinking about this clinically. The second piece is that the prevalence is actually extraordinarily high in black women. And if we think about this, actually in this population, they said that the prevalence rate was 1 in 280 women. So this is suddenly not a very rare disease, right? If we think about that among those population. And again, this is about as common as celiac disease is in the white population. So again, just anchoring us as we start the talk today. But again, this was the study where they demonstrated that their black population was 7-fold more likely to develop end-stage renal disease than their white population across this cohort. And again, in the same cohort, they were able to demonstrate that the mortality ratio was very disproportionate by race. One, they showed that actually, for instance, at 5 years, about 20% of their cohort in the black cohort had actually died, versus between years 4 and 5 was their first fatality among their white patients in their lupus cohort. Again, showing us a huge mortality disparity. And again, some of this we can ask, is this differences in the disease? And some of this we can ask, what else might be driving changes like this that we see? These time trends have also been looked at, and these racial trends have been also looked at using U.S. Vital Records data. So when we use U.S. Vital Records data, just to orient you a little bit on this slide, this is a publication from Annals of Internal Medicine in 2017. And on the x-axis, we see 1970 to 2010. On the y-axis, we see actually what they're representing here is the ratio of mortality in lupus patients to non-lupus patients. Again, here what they would show you if they had it superimposed on the slide is an improving line over here for general overall survival among people in the U.S. over this time trend. And what you see is actually going in the opposite direction when you look at that ratio, where around 2000 actually was the peak of the the biggest gap for patients with lupus. And when they break this down, which they actually did in the appendix and not in the article proper, but when they break this down by race, we see that actually in those white squares down at the bottom, white people have been doing decently well all along, although, unfortunately, lupus does have a inherent disease-related higher standardized mortality ratio than age and gender matched peers. We see that Asian patients were doing better over time in these yellow circles, but we see that most of that trend actually was driven by this racial disparity in the black population. So again, kind of just asking ourselves some questions, saying, okay, the other piece here is that we saw some changes that were based on race. We're also seeing some time trends, which again would suggest perhaps this might not be entirely genetic or physiologic and that there might be some other factors. When we take a look through here, the other piece that we can take a quick look at is looking at, again, end-stage renal disease that we mentioned before. And this was an interesting study where they used all the US RDS data, and they looked at racial disparities as far as likelihood of just getting of developing end-stage renal disease after anybody just had nephritis. And what they showed was that actually, again, that peaked around 2000 as well, and that relative proportionality of that was strongly disproportionate in the black population, where they were about 15 times more likely to develop end-stage renal disease, and again higher prevalence in the Hispanic and Native American populations. Actually, one quick thing to highlight here too is that this reference for this is the Lupus Initiative, which is a lovely website that has information both for providers or educators who want to talk to learners about health disparities, but it also has a great patient-facing information source where there's lots of information and vignettes to share with patients about lupus. So again, we talked a little bit that there's some variation by race, there's some variation over time, but interestingly, there's also variation over location in the world. So they've been able to demonstrate that in Europe, when they look at the prevalence of nephropathy, for instance, in a cohort of 1,000 patients in the Eurolupus cohort, prevalence was around 28% having ever had any version of nephropathy with their lupus. And when they break that down in a U.S. Lumina cohort, interestingly, patients in Texas were twice as likely as the same ethnicity Hispanic patients in Puerto Rico to have ever had detected nephritis. And likewise, African Americans were more likely than about 3 times more likely than Caucasians. So again, suggesting that we're seeing some variation even by location. And that was underscored further in this study by the SLIC cohort. And SLIC is a cohort of nearly 2,000 patients from 12 different countries. And I think one of the interesting things here that I'll draw your attention to is that here they separated African descent patients in the U.S. from African descendant patients elsewhere. And actually the U.S. African patients had more damage. Showing you again the suggestion that perhaps some of this is mediated by how we deliver care, and perhaps not all genetically or otherwise physiologically driven. So that's the first kind of pause on this slide. The second piece is to kind of take a look at what else predicted damage. So the other things that predicted damage on the slide, some of these things, or predicted protection, are also, I think, worth calling out. One is that antimalarial use, so hydroxychloroquine, right? People have heard of this as the classic drug for lupus. And hydroxychloroquine use actually was the most protective factor, about 40% protection against new organ damage. And we also know this prolongs life in lupus. We know that corticosteroid use actually was a negative factor, but the other thing that was interesting that predicted damage was actually hypertension. And some of you know that we've been targeting hypertension in our clinics, kind of clinic-wide, thinking again at a population level, what can we do to reduce damage from our diseases? And this is another piece of evidence that that's actually a really important piece of the puzzle. So we talked about the fact that there's some changes over time, over race, over location. And then the other piece of the puzzle with lupus is that there's also changes over socioeconomic status, where they've actually shown that even in well-adjusted studies that are adjusting for age, sex, race, ethnicity across the U.S. using Medicaid data, that the adjusted prevalence in the pink bars here of lupus and in the purple bars here of lupus nephritis is highest in the people at the lowest end of the socioeconomic scale, again suggesting that some of this might not be all physiologic driven. And yet when we kind of think mechanistically, how all does that happen, one of the things to know and to see is that there's also good data that show that people get lower quality care delivery often when they are minority race ethnicity, when they're in lower socioeconomic strata, when they're publicly insured, when they're in a non-academic setting, and if they get fewer visits. And I think some of this just seems intuitive. But the other piece is there actually is firm data to show that people who are engaged in high quality care get less damage, and this has been quantified to estimate about 40% less damage. And again, kind of underscoring our underlying theory of could we help measure each of these steps and try to think about how to improve health equity. So I'm going to just pause there and just point out that this actually pretty firmly meets this NIH disparities definition. If you look at how the NIH defines disparities, they say these would be differences in the incidence, the prevalence, the mortality, and burden of disease and other adverse events that occur among a specific population in the U.S. And for those of you who don't think about lupus every day the way I think about it, the other piece is that this is a big issue in the U.S. And in 2009, they estimated that health disparities cost about $82 billion, and by next year, that will have doubled to $126 billion in cost across all conditions. And in the sum of the last 10 years, it's cost the U.S. about $337 billion, and they actually, in this article, estimate that about $220 billion of that is actually Medicare costs for rework for patients who sort of missed preventive services in the African American and Hispanic population, which I think is kind of humbling, and again tells us that, and when we think about this era of evidence-based medicine, one of the next frontiers is thinking about evidence-based medicine for all, right, and how we can help secure the system a little bit better to help do that. So next we're going to actually transition, and I mentioned already that we used blood pressure protocols, which was something we actually borrowed from primary care literature to look at that issue. We next looked at actually borrowing from the HIV literature to say they are a field where, again, predominantly young, often minority, low socioeconomic patients were being burdened by that disease for years and years, and yet they have some evidence-based strategies that have improved these disparities, and we thought perhaps we could borrow from their literature. And where we started was actually looking at this HIV care continuum. And Dr. David Malbranch gave grand rounds last year and hit some of this, and other presenters here in our own department, again, have hit this. But for those of you who are not familiar with this model, this is a World Health Organization and CDC endorsed model that basically examines 5 steps of a care pathway and says that if we can measure each of those 5 steps overall in these disparity subgroups, that we could actually get to this outcome, which would be achieving viral suppression. So they say, 1, we have to get people diagnosed, 2, linked to care, 3, retained in care, 4, on therapy, and 5, we have a shot at getting them into viral suppression. And this model has led to a compendium of evidence-based interventions where they have over 30 interventions across the 5 care steps that have evidence that they can actually improve outcomes and reduce disparities. And so we wanted to borrow this idea to say, could we use this in lupus? And so we adapted this with permission from the folks at HIV.gov to look at the idea of could we get people diagnosed with lupus, linked to care, retained in care, on therapy, and then have a sporting chance at getting them in that low disease activity state or not having damage, permanent damage. And as I talk about this today, I'm actually going to start in a very practical zone, which is just talking about diagnosis. And there are a few new pearls and some new literature, including new classification criteria that I'm hopeful will be useful to all of you as we start there. The second place I'm going to go is actually to make the case that, again, we think that if we can achieve this 5-step continuum, that actually we could improve outcomes and reduce damage. And then I'll talk to you about our own work here that's really focused on this mid-step of this retention and care and linkage to care that's been work with folks in our group, and I'll highlight several people in the room to call out the great work that they're doing as well, and we'll go starting with diagnosis. So one of the things that's interesting about diagnosis, and a lot of you probably know this, but again, just kind of stepping back, is that they did a survey of patients who had lupus, and they asked them, how long has it been since you first got your symptom that, like, looking back now, you know was lupus? And it turns out they say that it was typically about 6 years before they actually got diagnosed. So some of that may be clinical delay, but some of that is it just takes time sometimes to accrue those symptoms to kind of figure out the puzzle. We know things like being in a rural location may actually delay that even further. There's some evidence globally for that. But one of the interesting things that's sort of a signal that you can detect is that actually in the UK, they were actually able to look back over a huge cohort of lupus patients, and what they saw was that 5 years before diagnosis, they were coming in about once a year. And then within that 1-year period right before diagnosis, these people's visits just dramatically upticked. They were coming in all the time. I'm getting nods from a few people in the audience here who've probably experienced this. But again, this can be a signal when people are coming in with lots of sort of nondescript symptoms. They were showing people up to 38 visits in the year before diagnosis. So again, just one little trigger to make us think, could this be lupus? And if we think this could be lupus, what's the quintessential lab test that we might all order? ANA. I'm hearing it from the audience. All right, perfect. And as if nothing is sacred, I'm going to tell you a little pearl that there's a little nuance to knowing how to order a proper ANA, and we're going to start right there. All right. So there was a great study, actually, interestingly, by David Pisetsky and Roven, one of the lupus nephritis gurus, where they looked at 1,000 patients that were actually, they met lupus criteria. A lot of people actually in nephritis trials. So they had kidney-proven lupus. Like, these people have lupus, and they basically used 4 methods to compare ANA methodology to look to see how many would rescreen positive in clinical trials. And what they found was that the error rate was around 17%, depending on what assay you used, which gave us a bit of pause. The great news is, that I'm hopeful will be encouraging to you, is that here at UW we use the most sensitive and specific method. We use immunofluorescent assay on a HEP2 set, which is the gold standard test. And essentially, that test not only gives you a titer, which a lot of you have seen, you know, that 1 to 80 titer that can be really useful, but it also gives you a pattern. And so one of the nice features about this, too, is that occasionally you'll see it comes back and it says centromere. And again, then you're thinking more like, oh, could this be scleroderma or systemic sclerosis or something else, you know, mitochondrial, other patterns that we can see that can tip us off. So not only the titer, but also the pattern. But again, that this immunofluorescent assay is the gold standard. The local thing to know is that locally, this is the test that's used at UW Health, but the UWMF lab uses an ELISA-based test, which is a less sensitive test. So if you have high pretest probability and you've ordered it at UWMF or SSM or GHC, they actually are using an ELISA screen, and you could specifically ask for an immunofluorescent screen, which would be a better screening test. So that's my first pearl for the group here today. The next thing is that actually we have brand new classification criteria. So these classification criteria came from the American College of Rheumatology and the European League Against Rheumatism, which I think sounds cool and maybe like a Justice League, I'm not sure. A little bit, yeah. They've got a cooler name than we do, that's for sure. These were robust criteria that were developed in a 4-phase step, and I actually got to participate in one of the Delphi panels for this development of these criteria. They've been robustly reproduced with global cohorts around the world of over 4,000 patients with and without lupus. And what they did is they compared them to the old 97 ACR criteria, the 2012 criteria. And really what they're seeing is they're seeing improved sensitivity compared to those ACR criteria. And they're seeing improved specificity as well compared particularly to those newer SLIC criteria, which some of you may have seen us kind of comment on that in our notes in the last few years. So again, both sensitivity and specificity in 2 rounds are showing that these are good. So what are these criteria and what's new? Well, they've made it a bit more complicated, but let me give you the high points. So they've actually divided into 7 clinical categories and 3 immunologic categories. And they say that, first of all, you have to have an ANA. But you have to have an ANA by a reliable method. So again, I gave you kind of the pearl before. Make sure you're using a reliable method to screen for ANA. The second piece is that you have to have 10 points total, and that at least one of those needs to be a clinical feature. And that you add up the point totals here actually using the highest score in any one block or domain. Let me cut to the chase on what's new. So what's new is fever is now included, right? How many people here have ever seen a lupus patient with fever, right? I mean, yeah, a lot of people. So again, it has to be proven that there's no other infection, because obviously people who are immunocompromised can get infected as well, but that's now on the classification criteria. Delirium is also now on the classification criteria in addition to psychosis and seizure. And low complement level is actually now on the classification criteria. So these are kind of useful to know that we've sort of widened the net on a couple of things. The other thing that's useful to know is that actually now when people have nephritis, they have 8 to 10 points. So again, they practically get grandfathered in as long as they've got the ANA. And now what they're saying is just a proteinuria threshold of 0.5. So not the classic nephritis threshold that the internal medicine residents learn of 3 grams or something like this, but it's just a half a gram. So my pearls here are just to remind you, get a UA, that $12 test can tell you a ton, and then get that ANA by immunofluorescence. And at this point, I'll just transition us making the case that really improving care overall can improve outcomes. And I'm going to show you a couple of key studies. So one is, this is a study done by Candace Feldman and colleagues at Harvard who looked at the U.S. Medicaid population. And they looked at people who were newly prescribed hydroxychloroquine, which is like the cornerstone for all lupus therapy. All lupus patients should be on this drug. And they looked at people who had new prescriptions, and they asked the question of, among people given new prescriptions for hydroxychloroquine, how many take it in the first place, and at a year, how many are still taking it with a refill threshold of at least 80%? And the punchline here is that 83% of their patients had either fallen off the wagon, started taking it and stopped, or had never initiated therapy. So that's the first pause, okay? My husband, the pharmacist, said that's because we don't make any money filling hydroxychloroquine, which is a bit of a cynical comment, but I was like, oh, boy, that crushes me. But again, just telling us that there's room for improvement here. He's not a cynic. He's just being honest, I think. But at any rate, but the other piece here is that this actually correlated, that the patients who stayed on therapy versus didn't stay on therapy were less likely to have hospital visits or ER visits. So again, this made a difference. There's also a great Canadian group that's shown that if you stay on therapy, that you can have lower lupus damage, you're twice as likely to achieve low disease activity, and you have lower glucocorticoid exposure. So again, showing that it really matters if we can keep people on therapy. So how do we know if people are on therapy? And again, I think this is a broad question that probably applies to everybody in the room, right? We think about people on antihypertensives and other antidepressants, lots of medications that have adherence problems. So there's some interesting data here as well, again, both in lupus and then from well beyond the lupus literature. Locally, Shivani Garg in our department has worked with Karen Hansen, Natalie Costadou from France, and others, and including myself. And she looked at a question of if we measure blood levels versus give patients surveys in the world's literature. She did a meta-analysis and actually showed that when we ask patients, they actually answer pretty reliably. That if we just ask patients about their adherence, the odds ratio for concordance there was almost 3. So it worked decently well. Again, these patients knew they were being tested, so it might not work quite as well in real life, but this is sort of an interesting, encouraging factor. And there are a lot of validated questions, though the problem is that some of these have up to 12 and 17 items, and that's a little bit cumbersome for routine practice, and that's one of the realms that we've really encouraged Shivani to kind of think about other ways that we can kind of improve and streamline that process, and she's doing some great work in this. One of the fun pearls here is that the NIH has a national adherence network, and one of the things that they tell people, and again, some of you know this, but it's just a good reminder, is they say use a normalizing introduction to say, patients tell me all the time that it's hard to remember to take medicines. In the last week, how many times do you think you've forgotten your medicine? And when you use that normalizing introduction, you get a lot more reliable response. The other piece that we can, again, borrow from other literature is just the evidence globally, looking at adherence and retention on therapy across other conditions. So you see here that among these studies, a ton of them, again, came from the HIV realm, some from psychiatry, some from COPDs, cardiovascular studies and things too. But you see that when Cochrane did a study looking at 170 different studies on adherence, that only 17, they said, were quality studies, which is sort of humbling to start with, and then only 5 actually showed that they both improved adherence but also improved outcomes for patients, which is sort of interesting here. They said that the things that were most successful were things that were multi-component, but there were no common elements, and so that was a bit humbling. There's one other study more recently that I think is sort of encouraging and actually suggests possibly that we could have a new tool that could be helpful for this, and that is that there's a study that showed that when we electronically monitor people's refill status, that we actually can strongly improve this. And I'm seeing some nods. I mean, they use this in clinical trials, right? So this kind of makes sense. But the EHR actually might be a powerful tool for this, where SureScripts is now sending back data to some people's EHR, and actually Epic can do this. I don't think, has anyone seen this happen here at UW Health? I have not yet, but I think but it's on the horizon. I know Duke and a few other systems have this, where it feeds back the number of refills that a patient has remaining on a prescription that you've written, for instance, so you can tell whether or not they're actually filling their medication, and this might be something that's on the near horizon that, again, could really dramatically improve things, so that's great. In the HIV world, interestingly, it wasn't that whole retention on therapy or this adherence issue that was causing the most therapy failures. It was actually retaining patients in care and keeping them coming back, and I'm seeing a few nods here. And so interestingly, I sort of theorize that this might also be a quintessential point for patients with lupus, thinking of my own experience. Some of you, I think, in the room also are, do the hospital service. And how often is it that you have a patient who had lupus, kind of fell out of care, and then comes in catastrophically ill, right? This sometimes happens. And so the question for us was, is that also an issue on retention in care? Is that also an issue? So in HIV, they define this as saying that patients have to have at least 2 HIV visits in a year. They have to have at least a viral load every 6 months. And we thought that might be a similar good standard if we could think about defining what lupus retention in care might look like. The second thing we wanted to look at was, what predicts retention in care, sort of who stays in care and who do we need to target to keep them in care. And then our goal was thinking, how could we really use these metrics to improve evidence-based care, maybe think about policy, and even thinking about, can we improve outcomes for patients over time? And to study this question, we actually partnered with folks at Medical College of Wisconsin. So at MCW, we went and partnered with them and actually identified all the patients who had lupus at MCW. So this is actually the third time we had done this. We had done all the lupus patients at Marshfield Clinic, we've identified all the patients at UW, and then we went to MCW and did the same thing. And our classification criteria were basically they had to have a code for lupus and a visit to a rheumatologist. They had to be alive through 2015 to be eligible to come back in and get visits, obviously. And then they had to meet, at the time it was using those ACR and SLE criteria, the older two criteria, because we didn't have the new criteria yet. And among the patients that we abstracted, about 500 patients, we identified nearly 400 patients who met criteria for lupus. And then we went through and kind of compared what those patients looked like at baseline. And at MCW, about 40% of the patients with lupus were Black. And among those patients, they were more likely to be younger, they were more likely to be urban, and they were 10 times more likely to live in the most disadvantaged quartile neighborhood when we use the ADI depth. So about 5% of white patients were living in the most disadvantaged neighborhoods, and 51% of the Black patients in Milwaukee getting care at MCW were living in that disadvantaged neighborhood at baseline. We then wanted to sort of just look at just descriptively how often are people being retained in care and what does that look like. And so again, we used this HIV WHO standard and we said that would look like 2 visits a year to a rheumatologist. And we said we'd count it if you saw an MD, NP, a fellow, anybody who's a lupus specialist. And then you needed to get at least 2 lab tests a year. Now, when people have nephritis, the nephritis guidelines actually suggest 4 tests a year. So we actually looked at that threshold as well. And when we looked at that, we basically looked at first this idea of 2 visits a year. And when we looked at how many patients had 2 visits a year after enrolling in the cohort, only 60% of patients had at least 2 visits to a rheumatologist at a year. So that's the first point, is that 40% of our patients were not being retained in care in this cohort. But the second place we looked was how many patients are getting their lab tests. And again, here we looked at that 2 lab threshold. So about 20% or 27% of patients were getting that. And then among the patients with nephritis, they did a little bit better. They were getting a few more tests. But again, knowing that they were supposed to get 4 tests a year, only 14% of their patients had 4 tests in their lab system. Likewise, the double-stranded DNA didn't do any better. It actually was 19% at the 2-test threshold and only 8% among their nephritis patients. We did ask the question, and some of you probably are up against this too, that some patients get local labs, right? So if we kind of see some nods, we deal with this every day, I think, here at UW Health, that patients are getting local lab testing outside that may or may not be recorded in our system. So we actually went back to this visit-based definition when we went to look to what would predict, saying that we know we have capture of those visits. And we went to say what predicts this. We actually used a multi-level model from the National Institutes of Minority Health and Health Disparities framework, and we basically said we should account for some biological factors, including how severe your lupus is in the first place, which we kind of figured would probably influence how likely you were to come back in. We accounted for things like smoking, your race, ethnicity, whether you were rural or urban, knowing that, again, getting those lab tests done or getting to a clinic might be harder if you live far away. And then we accounted for that ADI, that neighborhood disadvantage. And again, a lot of you have heard great work by Dr. Amy Kind and others here at UW who've really looked at quantifying that neighborhood disadvantage construct. And the brief here is just showing you that this is using a 9-digit zip code to get really granular census block group level information about neighborhoods. And this includes a composite of factors like education, employment, housing, and neighborhood poverty. And you can jump onto the neighborhood atlas at medicine.wis.edu, and you could look at your own hometown, which is kind of interesting, or some other places. And it is interesting and terrific data here. But we use this to look at Milwaukee County and to look at what we would expect as far as retaining patients in care in this lupus cohort that we were looking at. And our hypothesis was that patients in the disadvantaged neighborhoods, which you'll see here are the urban center core of Milwaukee in the red and the most disadvantaged, would have lower retention in care than perhaps people at the lakeshore and the more advantaged suburbs. And when we looked at this, what we found was that, in fact, race and ethnicity did not predict who stayed in care. I'm getting a little bit of a surprise nod. It surprised us a bit, too. But, in fact, all of this actually loaded on ADI disadvantage, that disadvantage actually predicted 60% lower retention in care. Living in a poor neighborhood made you 60% lower to have at least 2 visits a year. Likewise, actually, people who had a history of smoking were slightly less likely. So again, that was a little bit of a surprise that was the main predictor, and I think it kind of gives us a little bit of pause to say, okay, now what can we do about that? And I think it's encouraging that Dr. Kind and others in the Health Services and Care Research Program we're thinking about this, but she's been in talks with folks thinking again that ADI would be something that we could include as far as information about patients, so we could kind of know who might be vulnerable to the care gaps that we could target to reach out to. And again, I think these are kind of encouraging things that again we could think on how we might be more aware and extend services. But the other place to look for possible interventions is, again, going back to our colleagues in ID and in the HIV realm and saying, what have they learned that we could borrow? And one of my favorites of that compendium of evidence-based interventions is actually this idea of virology fast track. So first of all, it has a great name. But secondly, what they were able to do was, like I said, this example before, where patients perhaps were hospitalized. They knew they had lupus. They just hadn't been in a while or hadn't gotten their labs done in a while. The great thing here is that this actually automates using the electronic record to capture if somebody hasn't been in for a visit for a while or hasn't had a lab for a while. And then it actually tees it up for the healthcare team so that they can do outreach to get those patients back in care. And what a cool idea that is. And it actually tees it up and makes it really easy to do that. So that's kind of a fun example of where we might be able to borrow from the literature and use interventions that might be able to improve this. And we're encouraged by that. There's other evidence in HIV. They talk about things like doing these strengths-based management, where they address issues like food and housing and give relationship support, and they've got strong evidence that they can improve retention with that. They co-locate clinics for that people can get testing and care in the same center. And in lupus, we're just getting to start thinking about these things, about what could we do to improve retention and care, and what could we do to improve care delivery. There's a study at Medical University of South Carolina where they're doing peer support, which kind of makes sense. There's a study at Northwestern and in Boston where they're using community health worker models. And then there's kind of a fun study actually from Emory where they're using just general chronic disease management. So again, thinking about like diabetes, chronic disease management, that those classes exist in a lot of different health systems. They actually are sending patients to just generic chronic disease management classes, and it turns out that they can improve their adherence to therapy and their outcomes by just sending them to just a disease-agnostic chronic disease management class, which is kind of interesting here as well. Here at UW, we've taken a couple of steps forward, and I'm really proud of work that Dr. Shivani Garg and others here have done, including setting up the UW's multidisciplinary lupus clinic, where we've got a pharmacist or a pharmacy student there, a social worker there, and then Dr. Tripti Singh and Shivani have developed the UW Nephritis Clinic. And I'm going to tell you a little bit about their work that was just recently highlighted in the UW Vital Signs that some of you may have seen. So the great thing there is that, or one of the great stories there is that when Shivani was ready to set up, or thinking about setting up this clinic, I encouraged her to partner with Sarah Panzer, who's also Department of Medicine faculty, who has a terrific database of all the people who've ever had biopsies at UW Health. So they had all the nephritis biopsies in this cohort, and we've looked at the time from referral to nephrology to the time of biopsy to look at what the wait time was on that. And we actually compared 2 different decades, and there was no difference across the 2 decades. It was about 52 days to mean time to biopsy, and she had published or has shared these results at a national meeting. But the great fast forward on the work of Dr. Singh and Dr. Garg is that now that they have the U.S.'s 5th lupus nephritis dedicated clinic, the mean time to biopsy is 10 days from that referral to outcome. So again, we'll be looking over time to see if this really changes the curve, but this is really encouraging early data to say that, again, changing the care model could really change the outcome, and kudos to them for this great work too. So at this point, we've really defined the lupus care continuum. We've defined that specific thing of retention and care that we're really interested in. We've talked about those predictors that might be things like low ADI, maybe people who smoke, and then we in the future, our hope is that we'll be able to look at each of the steps in this 5-step continuum. We'll be able to do this in our other cohorts, like our Marshfield cohort or UW cohort, and then others across the country, including using the great Medicare resource that we have here, and then partnering with Emory that we've done recently at a grant, or in a grant in the Medical College of Wisconsin, and then really looking at this idea of can we bend and improve outcomes over time by measuring these steps overall and within different subgroups, with the goal of really informing evidence-based care and policy to really improve outcomes. And so some of that is a bit policy level, and I wanted to also wrap up kind of talking about some more practical things that we've been doing, and some more practical ideas that might be easily grasped within the grasp of clinicians here in the room, to also bring us encouragement as we kind of think about adapting some of these things. And I also want to highlight some work that others in the room have done. So the first study here is actually work done by Trevor McCown, one of our VA chief residents, where Trevor actually worked with us to just look at how does smoking predict time to lupus damage. And what he found was that patients who had a 10-pack year smoking history actually accrued lupus damage 7 years faster. So maybe smoking cessation would be a great target to help improve outcomes. This is actually right, if we think about a lot of the other things we've talked about are harder to modify, but smoking cessation is something I can modify. And so this was an interesting study. And then he showed that actually at lower doses, they had slower rates of accruing damage, again suggesting that probably cessation would matter. Nena Azay, a medical student with our group, did another great study where she actually looked at skin disease in association with smoking. And she was able to demonstrate, again, this pack-year relationship that looks like a dose-response relationship that was most significant at the high pack-year dose for chronic skin damage, this like chronic scarring skin rash that like discoid lupus can leave. And Nena is terrific and has worked with the public health department in California, and she's made the argument with me, you need to get the word out on this, because she said, young black women having disfiguring skin disease actually might be far more likely to motivate you to quit smoking than talking about cardiovascular disease, which is what I've been talking about for the last 10 years. So she gave me a great pearl here, thinking again that if we can kind of get different messages out about how this might matter, it might really help. So that was kind of, again, another fun study. And we are using these right now to implement our Quick Connect intervention, actually with partners at the Grady Public Hospital in downtown Atlanta. We're implementing actually later in about a month. And so stay tuned on that. This is a really brief kind of update. I think that I looked back at my slides from 2016 Grand Rounds. I talked to you all about some of the work we were doing on blood pressure and tobacco interventions. And that Quick Connect intervention is kind of a fun one. It actually takes about a minute at point of care, where our medical assistants who are asking patients every day, do you smoke? And then often in our systems then going to do you have any allergies, and not kind of acting on that information, that instead they actually do this quick intervention. And I think this has disseminated here at UW Health to a lot of the primary care clinics, and this has been really fun too. But in our rheumatology clinic, what we found is that by doing this brief point-of-care intervention where we ask about readiness to quit and offer to connect them to the quit line, we've 26-fold increased our referrals to the quit line. We've also done this actually at Gunderson and shown the same caliber of improvement there. Our BP Connect is a similar sort of a 1-minute intervention that when we room patients who have high blood pressures, we are actually just offering that if we get a second confirmed high blood pressure, we're offering to connect them back to primary care. And we've over the last 3 years, this has been sustained in our clinic, and we've published these results in the last year showing that we doubled timely primary care follow-up. But I think one of the other things that I'm really proud of is that we not only improve care overall, but we particularly improve care by about 70% among patients of black race in our clinics, that we got them back to timely follow-up. And the other cool thing is we actually have been able to show over 50,000 visits that we've actually decreased the population level of high blood pressure. So this intervention actually works. So thinking about things like protocols that help us do the right thing all the time can really make a difference. And again, this is sort of encouraging to me as I think about ways that we can address other social determinants of health, kind of thinking about that as well. One other kind of transitioning from the outpatient question, we also have been recently looking at the inpatient question of lupus care. And one thing that you all might not know is that when we looked at this in a U.S. Medicare sample, we actually found that the rate of 30-day readmissions in lupus patients was as high as heart failure. It's kind of amazing. So this is work that Ann Shadara and others have worked on with me. And this is kind of an interesting study where we controlled for a number of different factors, and we saw that compared to general Medicare patients who on average were about 20 years older than my lupus patients were actually at higher rates, at higher risk for rehospitalization. And some of you may have experienced this sort of, again, firsthand. But again, this is not a widely targeted population for readmission reduction strategies, but might be an important thing to target. I actually talked about these data with Ann Rosenthal, the chief at Medical College of Wisconsin recently, and she told me when they grabbed recent data, they were as high as 40% for rehospitalization rate. So again, a good target to think about where we can borrow what we've learned from other diseases like CHF or Amy Kine's great work and C-TREC work, and thinking about where we could apply this for patients with lupus. And so that's been another thought-provoking area for us as well. Maria Schleitzbaum, one of our grad students, is looking at this specifically in the young adults, because it turns out actually the youngest lupus patients were at highest risk for rehospitalization. And then we're looking further into other causes where we've seen some signal, for instance, that they have much higher rates of injury and poisoning as a category of hospitalization, and we're diving into that to see if maybe some of this may be opioid mediated again, knowing that if we can do a better job delivering and keeping people in routine lupus care, we can hopefully keep them off of chronic opioid therapy and improve their outcomes as well. So again, interesting area that can help push us forward. And it reminds me of I love the poet Mary Oliver. She says, "This is why I wake early." So this is why I wake early. So these are the types of things that kind of drive me to keep coming back to asking these types of questions, right? So this is another study that I think actually, again, it's one of the last studies that I'll present to you all, but it's one of the studies that actually came from outside, and I think it's just thought-provoking as we kind of think about how we all deliver care and how we all are sort of challenged and stretched to make sure that we're delivering the best care to everybody that we encounter in our clinics. And this was a study where they engaged 700 Black patients who had lupus, and they asked them, and they basically were looking at the question of, are their clinical outcomes correlated with how they perceive the quality of their interactions in clinic? Okay, so the columns here are disease activity categories. So they had about a third of people who had severe disease activity, a third who had moderate, and a third who had mild disease activity. And the question was, does receipt of care kind of predict where you fall on that spectrum? And first they looked at this idea of discrimination, and there looked like there was a little signal where it was slightly higher, it was modestly significant or moderately significant. Again, this implicit bias literature and things like this would always sort of say that this is true and this is part of the story. And this is certainly should be something that we're mindful of. But the other part of the story I think is also really interesting. And the other part of the story was that the things that loaded even higher was that when we were hurried or distracted, patients were more likely to, the patients who had severe disease activity were more likely to report that their clinicians were hurried and distracted or offered lower emotional support. Now, I've been in clinic with patients who have, 6 active issues, and it is hard to not be hurried and distracted at that point sometimes, right? We all could laugh at this, right? That it's sometimes challenging, but I think it's actually also sort of encouraging that some of the things that patients who maintained low disease activity reported were less likely to report distraction and were more likely to report high scores for emotional support. So again, saying that some of these things are in our control, that just reaching out and it makes sense, right, that the patients might be more likely to want to come back to our clinics if we're really connecting to them as individuals. And I think that's just an interesting take-home point here as well. Just as a humorous note here too, disrespectful office staff did not reach statistical significance. So it's on us, right? Okay, so this is on us. Okay. And on that note, I'm just going to kind of wrap up here also with this quote, this great quote from Maya Angelou, where she said, people will forget what you said, they'll forget what you did, but they'll never forget how you made them feel. And I think that's really a great take-home point of something that we can do sort of every day in our clinical practice. So we talked a little bit about how lupus is a leading cause of death, particularly among young women, how it is a major source of U.S. health disparities. We've talked a little bit about how thinking about it along a care continuum or measuring gaps at each step might improve overall outcomes for patients. And I'm hopeful that folks from lots of different backgrounds can think about also how we might leverage evidence from other fields to think about how we might improve evidence-based approaches in lupus and even beyond that. Again, thinking about whole-centered person-centered care, things like protocols for blood pressure and tobacco, readmission reduction strategies, and again, thinking about even things like chronic disease management classes that could be useful for people outside of kind of the traditional diabetes space, where I think we think of that kind of routinely. And so with that, I would love to just acknowledge all of the great people, including a few whose faces are highlighted here, but many others have contributed to this work, but these are just some of the folks whose work was highlighted in the talk. I'd like to thank all of our collaborators here at UW, including Dr. Garg in the Lupus Clinic, who's highlighted here, number of our trainees who are highlighted here, the Health Services Care and Research team, who's been great at helping to support this work, previous work that we've done with the cardiovascular team, including Heather Johnson, and our own research team. Also just acknowledging our collaborators, our funders, and at this point I'll pause and take your questions.
Fantastic. So please repeat the questions when they come up.
Thanks. Bennett.
Christie, I just always enjoy listening to you answering such fundamental questions of medical care. So given the 6-year period and the availability of smoking cessation, hydroxychloroquine, hypertension control, what would be the downside, psychologically or false positives, for going into neighborhoods of 15 to 40-year-old African-American women and screening people broadly for this disease? We're probably going to go universal on Hep C screening in the United States very, very shortly. What's the downside for us to go out there and early case finding?
A fascinating question. So the first downside I could say would just be, so the question, perfect, I love it, so perfect. So the question is a terrific one here. So saying, what would be the downside of doing universal screening, particularly, for instance, in young African-American women who are at the highest risk for this? And he gives the example of hepatitis C, which now has been recommended to be universal screening, and making the point that what would be the downside, or asking the question of what would be the downside of a universal screening type approach. And so one would be, generating, I think it might be generating angst in people who have sort of low titer ANAs and no other symptoms. Might be, again, just looking at what was sort of the unintended consequence of someone who has sort of a borderline test result and now has to think about that. But the flip side is they should be thinking, ask the appropriate questions of, do they have lupus? So I think this is a great question, and one that I will bring back to collaborators. I mean, the fun thing is we're collaborating now with the Grady Public Hospital that is like blocks away from the Centers for Disease Control and other people who think about these things a lot. And so these would be the types of questions that we could start to ask about how we can get people better connected to care. You probably saw some of the billboard campaigns, like in the last decade. They've been trying to kind of get the word out even in rural areas or in concentrated areas where they have patients with young African-American patients, for instance, but universal screening might have this unintended consequence of maybe undue angst in people who have low titer ANA, but I think the flip side is the benefit of that might outweigh that consequence, and that might be a great thing to study and ask. That's a great question. Others? Go ahead.
Christie, great talk.
Thanks, Ann.
Kind of a two-part question.
Sure.
So I'm a little disappointed being in a foundation clinic that all my ANAs are not being test, and can we rally to change that? The second concern is on the other spectrum of diseases like rheumatoid arthritis and other things, does that also pertain that there is a more specific test than the ANA that we do at that foundation class?
Okay, so that's a two-part question. So the first question was, could we rally to think about maybe the UWMF perhaps changing their methodology or their standards there? The second question was, when we think about things like RA, should we be thinking a little bit about test reliability in that? And I'll answer those in two steps. So one is, I'm not sure on the UWMF standard. The ELISA test is less expensive for them to run as an initial screen. If people screen positive on that test, it's a true positive. So it's a reasonable test in that realm. The thing to know is just that if they test negative and you still have a decent pretest probability, ask them to run it as an immunofluorescence. Or the other piece would be you could specifically just ask for that out of the gate, or you could have them get it drawn at a UW Health lab. So perhaps stay tuned. We could maybe think about engaging, but I think for now those would be kind of the two best strategies would be doing it as a sequential. That's actually in that article what they recommended was just doing a multiplex test where you sequentially, if they screen negative and you still have high test probability, maybe run a second test. So that would be the strategy. The second question on the rheumatoid arthritis, I think the great thing is We do have the CCP test that we can now do, which is highly specific for rheumatoid arthritis, in the 95% specific range, in addition to the rheumatoid factor that we can run. And I think it's reasonable to run both of those if you're screening patients for RA, to just run both of those. But I don't know of any quality issues, lab to lab on that test. Good question. Go ahead, Dr. Mackey.
The ultimate control of disease is understanding why it occurs.
Great.
Lupus is a genetically determined disease.
So,
It's an infectious disease. We haven't identified the path. Is there a lupus gene? If there is, then the easiest way would be to screen the population, be screened genetically.
yeah, it's a great question. So Dr. Mackey asked the question of, that fundamentally to control lupus disease, one of the things would be to just understand what causes it in the first place. For instance, if there was a gene, could we universally screen for that gene? And I think it's a great question, but the humbling answer, and I thought maybe someone might ask this, so I tucked the slide in here. But the humbling response to that is that there are over 90 genetic loci that have been identified, and people think even combining all of those aspects, that explains less than 40% of the lupus variation. So humblingly, right now we have so many scattershot things that show up differently in patients that we can't use that approach yet. So stay tuned. We may be able to, about 60% of patients with lupus have some sort of interferon problem, but there's lots of different points where that happens, right? So it's hard to know of a direct screening test right now. I actually also tucked this in here for the nephritis. Last year for Research Day, we had a terrific talk where they were talking a little bit about, for instance, genetic risk for renal disease. And interestingly, when they look at renal disease with the same genetic marker that is a huge marker in the African American population and the general population, when they look that same marker in lupus, it explains a 2-year acceleration, but that's not a 7-fold increased risk, right? So we're yet to find out. And again, that's another encouraging thing, is really there's a ton of, for those of you who are in the room who are interested in basic science research, there's a ton of basic science research that needs to happen in this space too. There's some encouraging new funding that's happening, like DOD actually has huge lupus grants now, so they're starting to generate this. Maybe Kim Kardashian can help us with that, generating money. But a good question. Go ahead.
Thanks again. Delightful.
Thank you.
And what I'm wondering is, you described this strategy, translational strategy from like the HIV field, and certainly also about like frail homebound individuals who can't access clinic.
Good.
I think a lot of the things you shared with us were kind of clinic-based strategies, but undoubtedly in some of the other
That's a great question.
collaborators you're working with, they probably are doing community-based strategies, being intentional to get out into the community rather than expect to come to us. I'm curious, so what kinds of community-based strategies have you considered?
This is a great question. So one of the things, this is interesting, but when Anne,
Repeat the question.
oh please, the question, thank you. The question is, what community-based strategies have been considered in lupus? And he gives the example of homebound individuals, being a geriatrician, kind of thinking about, again, rather than expecting the patient to come to the clinic, thinking about how we might go into the community to better deliver care. And that's a great question. So I think these are great questions. I think that thinking of a few specific examples. One is actually the conversation I had with Medical College of Wisconsin after showing them their own retention data, that they actually started a lupus clinic there, and they're thinking about maybe doing some of their lupus outreach actually at a downtown location rather than at the suburban center, which again kind of makes sense, right? So this would be one. I think our co-located clinic with the nephritis clinic, not expecting them to go over to the separately to the dialysis center, and where again, if you come see a rheumatologist and then they order the referral, then you're in a sequential queue, and that's part of that 52-day wait. So kind of co-locating these services, I think, is one example. But I'm with you that I think that we could be even more creative about how we might be able to, if we're expecting to get labs 4 times a year for nephritis, could we get home health to draw some of those labs, or could we get a community option? Certainly we try to give people local lab slips, which is part of why I mentioned those missing data. I often do that for my rural patients. I give them local lab slips. I have them, but the trick with that too is that if they've had it drawn and I didn't get the result faxed to me, I actually don't know whether they've had it drawn. And so this can create some, but I think absolutely innovating outside in the community is a great question, and I guess it comes back to also the strategies that we're thinking about too, about universal screening or other places to do some outreach. Those are great questions and great food for thought, so thank you.
One last question.
Dr. Carnes.
So we think of lupus as a disease of women, the vast majority of I'm wondering if, just like breast cancer, men are disadvantaged because we think of it as a disease only women. Were men even more delayed in the diagnosis in some of the studies you looked at?
That is a fabulous question, and I will have to get back to you. I actually don't know that answer. We do have the data from some of our Marshall cohort. I mentioned that our gender ratio is 5-to-1 at Marshall because a lot of these cases are late onset, so we could look at that, and I don't know, and I don't know that whether that's been published or not either. But it's a great question of whether the question was whether men might actually be disadvantaged because our cognitive bias might actually bias us toward thinking about this in women rather than men. So that's a great question.
Thank you very much.
Thank you.
Dr. Bartels,
Thank you. Thank you.